Hello, good evening, guys. You are once again welcome to NEET PG Live Daily. And in the series of this endocrinology drug, we have already covered thyroid. We have covered, we are covering antidiabetic hormones. So, first part of antidiabetic hormones, antidiabetic drugs has already been covered. And in the first part, I in fact talked more about, entire session was on the insulin itself. So इस क्लास को अटेंड करने के बाद आपको लगा होगा कि इंसुलिन के बारे में बहुत सारे जो इंट्रिकेसीज हैं, जो आपके डाउट्स थे, वो क्लियर हुए होंगे इस लेक्चर से. तो अगला लेक्चर जो मैंने रखा है, इसमें वी विल बी डिस्कसिंग रेस्ट ऑफ द ड्रग्स विच आर यूज्ड इन डायबिटीज़ मैनेजमेंट. I in fact dedicated one entire class to insulin and the physiology of the pancreas, diabetes and all that. So आज हम बात करेंगे बाकी एंटी डायबिटिक ड्रग्स के बारे में. ये इस सीरीज़ में चौथा लेक्चर है और अगले क्लासेस में मैं पिट्यूटरी हार्मोन्स एंड रिलेटेड ड्रग्स के बारे में बात करूँगा. ठीक है. मैं उन लोगों को अपना परिचय दे देना चाहता हूं जो पहली बार इस क्लास को अटेंड कर रहे हैं, मुझे देख रहे हैं या नीट पीजी पे लाइव डेली पे पहली बार आ रहे हैं. तो मेरा नाम डॉक्टर प्रमोद शर्मा है. मैं सुपर स्पेशलिस्ट हूं इन क्लिनिकल फार्माकोलॉजी और मैंने एमडी और डीएम पीजीआई चंडीगढ़ से किया है. और मैं ब्रांड एम्बेसडर हूं बेंथम साइंस पब्लिशर्स का. और इसके अलावा मुझे राष्ट्रीय गौरव अवार्ड भी मिल चुका है. बच्चों, मैं आपसे ये बताना चाहूँगा कि ये जो टेलीग्राम चैनल है, ये जो दो ऐप है, ये ऐप आप ज़रूर डाउनलोड कर लें, क्योंकि इस ऐप के ज़रिए आपको सारे नोटिफिकेशन मिलते रहेंगे. लेकिन सिर्फ ऐप डाउनलोड करने से काम नहीं चलेगा. आपको उसके अलावा you have to install it on your system and be part of this particular group, this livedaily.me/chat. इसके जब आप इस ग्रुप के हिस्सा बनोगे तभी आपको सारे नोटिफिकेशन मिलेंगे, जो कि आइदर एजुकेटर्स के द्वारा भेजे जाएंगे या फिर अनअकैडमी गाइज कैन सेंड इट. एंड इसमें आपको सारी इन्फॉर्मेशन मिलेगी कि कौन सा टॉपिक कब कवर किया जा रहा है, कौन एजुकेटर होगा, कौन सा टॉपिक होगा, किस वक्त लिया जाएगा. ये सारी जानकारियाँ आपको बिफोर हैंड मिल जाएंगी. तो आप अपने जो बिजी शेड्यूल है उसमें से टाइम निकाल कर आप अपनी मनपसंद की क्लासेस देख सकते हैं लाइव. इसके अलावा आप चाहें तो आपको कोई आपका फेवरेट एजुकेटर है तो आप उसे उसकी सारी क्लासेस अटेंड कर सकते हैं. तो ये एक अच्छा आइडिया है जो आपको पहले से बता देता है कि आपको कौन सी क्लासेस कब होने वाली हैं. तो एक तरह से आपके लिए टाइम टेबल का काम करता है और ये ज़रूरी है, इसलिए आप इसे ज़रूर डाउनलोड कर लें और अपने सिस्टम पे इंस्टॉल करें. Unacademy की एक Unacademy has a new service that is called Plus, which is for those who are preparing for NEET PG or other PG entrance examination. This is a subscription based service और इसमें कुछ Unacademy ने स्पेशल सर्विसेज ऑफर कर रहे हैं, इसलिए इसको प्लस भी कहा जाता है. दैट इज़ द रीज़न इट हैज़ प्लस फीचर्स. तो इसके क्या क्या फ़ायदे हैं, व्हाट इम्पॉर्टेंट सर्विसेज इट इज़ ऑफरिंग, बिकॉज इट इज़ अ सब्सक्रिप्शन बेस्ड सर्विस. द बेस्ट पार्ट ऑफ इट इज़ दैट द नंबर ऑफ लर्नर्स ऑन एनी प्लेटफॉर्म आर ऑलवेज लेस. Same is this Plus has less number of learners than the learners on free classes. So here these classes are more interactive. Student and the educator interact quite often, and you can very well interrupt the educator in middle of the class and can ask for any question, any doubt, any query or any clarification of any concept based question, etc. So this becomes a little more interactive session, and this actually I would rather say that this is the better way of transmitting information from educator to the learner, because unless there is no good communication between learner and the educator, any learning process can't be that efficient or effective. So this is the crux of the any learning process. And other than that, there is facility for live polls leaderboard, because this you get the information you get from this leaderboard and all that actually makes you more competitive, because this leaderboard gives you an idea about the performance of your colleagues, and you can always compare your performance with your peers, so that you get an idea whether you are on right track or you need to work hard on certain areas. And you can cast a poll regarding the quality of the classes or any feedback you want to share, that you can do. So these kind of facilities being provided on this platform. Other than that, as a study material, you have no dearth of study material on this platform. You have test series, the quizzes, and with their analysis and all that. The more you do, more you learn, and better you perform in your entrance examination. And as per the mandate of this Plus service or Plus platform, we need to take a doubt clearing session after every 3 sessions that have been conducted. So this give you another opportunity, or other means further opportunity to ask in YouTube live daily. So this is one subscription with unlimited access, and it caters to all your need. Whatever you need, it has every ingredient incorporated in it to meet all your requirement. So this subscription based service has different rates for different duration of subscription. It varies right from 1 month to 24 months, and the cheapest one is, if you consider month wise, it is the 24-month subscription, which is the cheapest. And these are the original rates, but if you use referral code of an educator, you become eligible for 10% instant discount. So whenever you pay, you don't forget to put the name of your favorite educator, so you can get 10% discount. For example, like for 24 months it was 40,000, now it has become 36,000. And those who subscribe for any period of subscription, any time period of subscription which is equal to or more than 6 months, he gets an opportunity to pay it in no cost EMI fashion. So this is little easier on your pocket as well. So these are the rates, and although the subscription is available from 1 month to 24 months, but we mainly recommend these two subscription model, usually these periods 12 months and 24 months. The reason being, the 12 month is mandatory, because being attached, if you are attached to Unacademy for a month or so, or 2 months, it doesn't make any, it does not bring any benefit to you, because you to understand the entire this thing, the plan, the strategy, the guidance that is being offered by the educators to clear the exam and all that is not, you will not be able to get all these benefits in a month or two. You need 12 months at least attachment with this Unacademy, so that you come across all the educators who will be teaching you different subjects of this medical specialty, as well as these educators, based on their experience and expertise, they keep posting special courses on this NEET PG Plus platform. That is, those courses are a number of times, or majority of the cases, they are actually maybe a particular exam specific, and many times these are the revision courses, or crash course, basic course, comprehensive course, all kind of need which and a PG aspirant can think of. So you will be exposed to more and more courses, and the syllabus, entire syllabus will be covered, and that will take in fact some time. That is why it is said that you stick to this subscription at least for 12 months to derive the maximum benefit out of it. The 24-month subscription is good enough for those guys who are still have not cleared their final MBBS, and they are still in the competition mode right from today. So for such guys, they can go for 4-month subscription, because it is the cheapest one, as well as not only it will help them prepare for their PG entrance, but that can help them obtain better marks in their final year university exams as well. And nobody knows, they can do wonder once they appear for their PG entrance for the first time. So this is the best which can be offered to the learners. These two durations are the most important duration of subscription, which one should go for according to their own need. So see, this is the rate has been given after application of 10% of discount, but for that, as I suggested, you need to apply this code Dr. Pramod, and for 12 months you need to pay only 24,750 instead of 27,500. But don't forget to apply this referral code. You can pay by different digital mode, whichever you feel is convenient for you. So this was all about the NEET PG plus subscription based service, because it offers many things which you will not be getting at any platform free of cost, and it's not a bad bargain, and you will after joining you will realize that it was worth joining this particular course or particular platform of Unacademy. So the today's topic is the part 2 of the pancreatic hormones and anti-diabetic drug. The hormones we have already discussed, but we will be discussing about amylin analog that is also being released by pancreas, but other hormones like glucagon, like peptide, glucagon, and other things we will also be discussing, those their incretomimetic drugs, etc. So let us start with sulfonylureas. Sulfonylureas are, as the name suggests, they are all having sulfonamide moiety, and they are very old drugs and being used in treatment of type 2 diabetes mellitus since ages. And now, because availability of the better drugs, which are called second generation agents, you can see these second generation agents, the glipizide, gliclazide, glyburide, that is also called glibenclamide in different countries, and glimepiride. So these drugs are actually second generation drugs. We hardly use first generation drugs that are very old drugs because they had certain shortcomings. For example, we had tolbutamide, acetohexamide, we had chloropropamide, etc. So these drugs are no longer used. We have these better drugs. And this diagram, in fact, in the first half of this class last time I discussed, but the diagram was different, but the things are same. You can see that when after the meal blood glucose level increases, that enters the beta cell through GLUT1, and this glucose is metabolized, forms ATP, and when there is ATP to ATP ratio increases, this ATP binds to ATP sensitive potassium channels. These are inward rectifier potassium channel, and after binding to this nucleotide binding domain, they actually close this channel, ATP channel, and that prevents there was persistent loss of potassium ion or efflux of potassium through the cells that was keeping the cell membrane in resting state or non-depolarizable state. But the moment this is closed, this channel is closed, there is a net retention of positive charge, and that can lead to a partial depolarization, ultimately leading to the opening of sodium channels, full depolarization, and calcium channels. And the entry of this calcium leads to exocytosis of the insulin, and this was the entire phenomenon behind the release of insulin secretion. So this channel also have sulfonylurea binding site that is actually exploited by these drugs, because once they bind to these site, they act in similar fashion as ATP was doing. They close these channels, and similar kind of effects are observed, and ultimately leading to insulin release. So these agents are also known as insulin secretagogues, right? So these are insulin secretagogue. The clinides, which has been mentioned here, the name suggests clinides. These group of drugs I will be discussing, they also are insulin secretagogues, means they release or force beta cells to secrete insulin. But important one is that for which some prerequisites are there, otherwise these drugs will not be effective at all. For example, these drugs not only cause release of insulin from the beta cell, but they indirectly inhibit serum glucagon level, which actually in type 2 diabetes mellitus patients is increased after post meal increase in serum glucagon level, and that can cause increase in postprandial hyperglycemia, can add to postprandial hyperglycemia. But this the release of this insulin through sulfonylurea can indirectly inhibit the glucagon level also, and that is probably due to the increase in release of insulin as well as release of somatostatin. And I told you somatostatin is the inhibitor of both glucagon as well as insulin release. So this is an indirect effect of the sulfonylureas. They do not only release insulin, but they also inhibit the secretion of glucagon, thereby decreasing its serum concentration. Up to this point, things are clear, but you should understand this fact that these drugs stimulate beta cell to secrete insulin. If these beta cells are not there, they are all damaged, like it happens in the there is selective loss of beta cells in type 1 diabetes mellitus. But and suppose there are no beta cells, from where this insulin will be released, then the sulfonylureas will not be effective. So at least for their effect to be exhibited, there should be some functioning beta cells should be there. So the threshold has been kept at 30%. There should be at least 30% functioning beta cells. But with time, gradually what happens, this beta cells keep decreasing, and ultimately a time comes that patient can be managed only with insulin. So then occurs the secondary sulfonylurea failure. That means with time, because there is continuous loss of beta cells down the line, and ultimately the patient fails to produce enough insulin with sulfonylureas. The phases of insulin secretion which I discussed in the last class, there was a brisk release after the meal, which was the first phase, which is usually affected in the type 2 diabetes mellitus. But the second phase, that was increase in insulin release, but prolonged increase, and that is less marked increase in the insulin, but that was the prolonged increased release of insulin. So the sulfonylureas mimic that insulin release similar to phase 2 release kind of thing, that mimics that kind of picture. It is not enough sufficient to cause brisk release of insulin as occurs during the in response to meal during the first phase of stimulated insulin release. So I told you that they release insulin, they inhibit glucagon secretions, as well as for the reaction to occur, there should be some functioning beta cells should be there. Their pattern of release of insulin mimic more like second phase of release of insulin that occurs physiologically, and some of the agent, especially this glimepiride, actually increases insulin sensitivity as well as decreases the hepatic glucose output as well. This has been demonstrated for this particular agent, right? So let us know more about the sulfonylureas. I told you that these second generation agents are preferred over first generation because first generation had more side effects and other complications associated with them. The second generation agents are preferred, the reason being they are more potent first of all, and they have less drug to drug interaction. This is also important because a diabetic individual is more likely to have other comorbid condition, for example diabetes. Along with diabetes, there may be hypertension, there may be cardiac diseases, there may be hypercholesterolemia. These all may coexist. So the patient must be receiving medication for those conditions as well. So there are more likely chances that, or it is much likely that the drugs can interact. Drug interaction may be there. So having less drug interaction is always a desirable property for any drug used in these conditions. As these drugs help diabetes patient by enhancing or stimulating insulin release, so this drug is to be administered before meal, at least 45 minutes, half an hour to 45 minutes before meal, as we were doing in case of regular insulin. Because this regular insulin, that from the site of injection, it gets gradually absorbed because these hexamers are converted into monomers. After they get solubilized in the local tissue fluids and all that. So similarly, this drug needs to be absorbed from the intestinal tract and reach to its site of action in the pancreas, that is beta cell, and should be able to release insulin. So it has to be given at least much before the meal, actual meal you consume. So by the time you consume your meal, the drug is ready to show its action. That is why it is to be given half an hour to 45 minutes before meal. This is the principle of treatment. You must know this. Whenever you give us insulin secretagogue, that should be given well before the food or the meal. Most of these agents, or almost all agents, can be given once daily. They are sufficient in once daily dosing. But when you use higher doses of certain agent like glipizide or gliclazide, you may divide the dosage in two. You can split doses. Otherwise, once daily dose is more than sufficient for most of these agents. These drugs needs to be avoided in certain renal and hepatic conditions, which leads to impairment of their function. Especially the glyburide and the glipizide. Both the drugs should be avoided in renal or hepatic dysfunction. Side effects, as these are insulin secretagogues, they release insulin, and if you suppose you do not take enough carbohydrate relative to the doses of sulfonylurea you are taking on regular basis, or you have by mistake have consumed little more doses by mistake, or you had some unusual physical activity, etc., that may precipitate hypoglycemia. So hypoglycemia is one of the important cause of any hypoglycemic drug, let it be insulin or anything. So as I always tell you that if you are using antihypertensive drug, the most common side effect will be hypotension. If you are using anticoagulant, the most common side effect will be bleeding. If you are using hypoglycemic, the common side effect will be hypoglycemia. So these are just extension of the pharmacological effect of the drugs, and these kind of side effects are called augmented reaction or type 1 adverse drug reactions, or type A, augmented type. And weight gain can also occur with the sulfonylurea because they increases the systemic exposure, the body exposure to insulin, because they are promoting insulin release. So insulin is an anabolic hormone. I discussed everything about this. This leads to protein anabolism, the lipogenesis, as well as the glycogenesis, etc. So all these factors can lead to weight gain. But however, this weight gain and hypoglycemia, both the problems have been reported or less frequently with glipizide. So glipizide is involved at many places, but it has this good effect that the weight gain and the hypoglycemia complications are little or occur with a little lesser frequency with glipizide in comparison to others. Another group of insulin secretagogues are the glinides. We have two agents under this category, that is ripaglinide and natiglinide, and they act similar to sulfonylureas because they act on beta cells, similar the ATP sensitive inward rectifier potassium channels, and they might bind to the same site on the sulfonyl SUR1 unit, or maybe some overlapping site, but the ultimate result is same. They also facilitate the release of insulin. But unlike these sulfonylureas, these glinides have faster onset of action. The reason being, after their oral administration, the peak levels are reached within 1 hour, and they also have shorter duration of action. For example, natiglinide hardly has duration of action is even less than 4 hours. Ripaglinide maybe 5 to 8 hours. So these drugs have little shorter action, and that is the reason why they are good in certain situations or can have certain positive properties associated with them. For example, because of their shorter duration of action, the risk of this late postprandial hypoglycemia is significantly reduced. So in comparison to conventional sulfonylureas, these drugs have lower risk of serious late postprandial hypoglycemia because their duration of action is less. Similarly, in case of, as I was talking about, rapid acting insulin and short acting insulin, that is regular insulin. And efficacy is similar to sulfonylurea in monotherapy. Of course, they can also be used as monotherapy. Usually they are to be used just before meal. These drugs, because they have rapid peak, need not be given half an hour or 45 minutes before the meal. They can be given just before the meal, and because they are rapidly absorbed, their peak is little early, and that is why these drugs may be effective as monotherapy, as well as they can be combined with either the metformin or thiazolidinediones. They can be used in combination as well. So because of their fast reaction and all that, and they are usually taken just before meal, they are also considered as or named as oral insulins. Though they are taken orally, they are not insulins, but considered as oral insulin. And similar to sulfonylureas, they also require functioning beta cell reserves. Otherwise, these drugs will not be effective at all. They also, because of their rapid peak, they control postprandial hyperglycemia very effectively, because it mimics the physiological release of insulin more closely than these conventional sulfonylureas. I don't say that this is physiological release, but better than conventional sulfonylurea. So they have better effect on postprandial hyperglycemia, and they are associated with lesser excursion in postprandial hyperglycemia, and that is why and this is the reason why this short early onset of action or rapid peak is responsible for this particular desirable feature. Netiglinide is considered safe even in patients who have renal failure. And if you consider, the netiglinide is the safest oral insulin secretagogue agent which can cause hypoglycemia. It is, in terms of hypoglycemia, it is considered as the safest among all insulin secretagogue. And not only that, if patient has allergy to conventional sulfonylureas because of presence of sulfonamide moiety, this ripaglinide can be used as an alternative in case of sulfonylurea allergy. So this is another big advantage with these group of drugs. So these are meglitinide derivative. They are also known as meglitinide derivative, but they are also known as glinides. So I prefer the term glinides, right? Biguanides, everybody must be aware of this particular class of drugs, and only one drug is available in this group, that is metformin, and it is a very old compound, but is still the gold standard, you can say. The another agent which was there in this group, fenformin, has been withdrawn long before because of a serious side effect of lactic acidosis associated with it. Though this metformin is better known as an anti-hyperglycemic drug rather than hypoglycemic drug, because even if you administer this drug to a patient who do not have hyperglycemia, it will not cause hypoglycemia. It causes reduction in blood sugar when it is raised. That is why it is better known as, or more aptly can be called as, anti-hyperglycemic drug. And it reduces hepatic glucose output production. That is the primary action of this metformin, by which it reduces blood sugar level. And this is possible only because it is able to stimulate this particular enzyme, that is AMP activated protein kinase. AMP activated protein kinase in liver. So the activation of this enzyme is actually the key factor which actually enable this metformin to bring down the blood sugar level. And not only that, this metformin can affect blood glucose intestinal glucose absorption, because it can delay or slow down the glucose absorption from the intestine. So it is also a good fact, because there is no sudden load of glucose which is being delivered to the central circulation. Rather, the glucose entry is slow, which can easily be handled by the lesser amount of insulin which is present in the blood. So this can slow down the glucose absorption, and it actually increases peripheral utilization of glucose also. That is the glucose uptake by the especially the skeletal muscles, adipose tissues and liver is enhanced. So this is not only it actually causes decreases the hepatic glucose output, that is a result of gluconeogenesis, etc. It slows glucose absorption from the intestine. It increases peripheral utilization by the peripheral tissues, and also it can affect it can produce anorexia as a side effect also. So that is also one of the reasons that can reduce appetite, and the overall consumption of the carbohydrate can be reduced. This drug is very unique in the sense that this metformin is neither protein bound nor metabolized. It is excreted as such in active form through kidney. This is excreted unchanged by the kidney. So any renal impairment may have complications, may manifest as adverse effects. So that is why this drug is contraindicated in patients, those who have estimated GFR less than 60 ml per minute. Earlier it was the specific cutoff mark for serum creatinine was there, that is 1.5 milligram percent for men and 1.4 milligram percent for women. But now it is eGFR which decides. So if it is less than 60 ml per minute, it should not be used, contraindicated. And also it should be contraindicated because is contraindicated in patient those who have received contrast media, who have undergone any radiological examination which required administration of contrast, because contrast have tendency to cause contrast induced nephropathy. So it should be avoided. The metformin should not be used for 48 hours after the administration of any contrast media for radiological investigation. And as I told you, this drug is better known as an anti-hyperglycemic drug. The hypoglycemia is essentially unknown. There is no case which has been exclusively any case report or any case which has come to the light of the literature that hypoglycemia has been resulted because of the metformin use. This could be ascribed to some other reasons or other causes, not to the metformin. And this metformin, it increases peripheral utilization of glucose, reduces gluconeogenesis, slows glucose absorption. All that actually reduces the requirement of insulin. So it has insulin sparing effect. So a person who is suppose on insulin using particular units of insulin, suppose 20 units, and if you added metformin, the insulin requirement will reduce, because metformin actually promote these kind or have these kind of actions. So these all actions may result in reduced requirement of insulin. This is called insulin sparing. So it has insulin sparing effect, and that is the reason why it is not associated with the weight gain, because the systemic exposure to insulin actually is rather reduced. So it is not associated with increase in weight gain, and it is a preferred therapy in individuals who are little obese or overweight or higher BMI at the start of the therapy. And still this biguanide, especially the metformin, is considered as first line therapy for type 2 diabetes mellitus, both and it is effective in controlling both fasting blood sugar as well as the postprandial blood sugar. And unless until there is any contraindication, this is first line therapy. If there is any contraindication, suppose patient is having renal failure, as I have said, that actually is a contraindication. So otherwise it is the first line therapy for type 2 diabetes mellitus, right? And it can be used in monotherapy, as well as it can be combined with sulfonylureas or thiazolidinediones. So it is available with various other anti-diabetic agent. This metformin is the favored combination with almost every agent, anti-diabetic agent. This is most commonly the combined drug with other agents. The drug is as considered as I said, the first line therapy or gold standard kind of thing, but the only problem with this metformin is it has a high percentage of GI intolerance. That is the reason many of the patients do not tolerate metformin and might discontinue treatment, but usually with time these tolerability issues disappear, but or one has to wait for some time at least for these problems to settle down. But one thing can be done to reduce at least the severity of this tolerability symptoms. That is, you can give metformin during the meal or after the meal. It is not necessary to be given before meal as in case of sulfonylureas and all that, because metformin's mechanism of action is entirely different. It does not require the administration just before the meal or etc. But by administering it during the meal or just after meal would definitely reduce this GI side effects. And the GI side effects actually are manifested in the form of nausea, sometimes could be vomiting, but rarely diarrhea, flatulence, and it can cause dyspepsia, can be observed in almost 20% of the patient, 1/5 of the patient being treated. So that is a big number, and this is one thing which actually brings little disrepute to the metformin. Otherwise metformin is a wonderful drug and still the most commonly used, the cheapest and the most commonly used drug available for diabetes. This lactic acidosis, let me explain you in little detail, because this is important. Though the lactic acidosis is a possibility with use of metformin, rather if it is used as per the instruction, as per the labeling information, it hardly causes lactic acidosis. Rarely any case of lactic acidosis has come into picture. But this occurs in situations like in individual those who are alcoholic. What happens in alcoholics, because of the metabolism of alcohol, there is deficiency of NAD, because that has all been utilized in large doses. It has been utilized. It is being utilized while alcohol is metabolized by alcohol dehydrogenase and other enzymes. So there is increase in ratio of reduced NAD to NAD, and this NAD is required by at every place in the TCA cycle. So this TCA cycle enzyme suffers because of this deficiency of NAD, and this pyruvate is converted into lactate, because this TCA cycle, this cannot be shunted to the TCA cycle, and this lactate level increases. So that is the reason that these alcoholics are more prone to develop lactic acidosis. Moreover, other things, other conditions which septicemia or dehydration, these are the conditions which are associated with increased production of lactic acid. Septicemia because of the very obvious inflammatory state and all that, and dehydration because this dehydration might lead to tissue anoxia and hypoxia, etc. Other than that, also any cardiorespiratory condition like CHF or any COPD, etc. These conditions can also lead to hypoxia kind of situation, tissue hypoxia, that also increases the production of lactic acids. So these conditions can make a person more prone to develop lactic acidosis. Other than that, there are conditions like renal failure. Why the metformin should be avoided in renal failure, hepatic failure. These are also conditions where there are high chances of developing lactic acidosis. In how renal failure can cause lactic acidosis, because I told you this drug is excreted unchanged by kidney entirely. So if there is renal failure, as I said, this is the cutoff limit when you should not use metformin, and if you are using, this will lead to accumulation of metformin, and metformin actually leads to enhanced inhibition of pyruvate carboxylase enzyme, which actually forms from pyruvate to oxaloacetate. So this process is actually, and this is the first step towards the gluconeogenesis. So this is inhibited. So actually this leads to pyruvate getting converted into lactic acid, and further it inhibits hepatic uptake of lactic acid as well. So this process, in higher concentration, this metformin can inhibit these two effects. So this may lead to increased lactic acid level. Not only that, this lactic acid is actually 90% of the lactic acid which is being generated is metabolized either in the liver or the kidney. 60% is metabolized in the liver. So suppose there is hepatic failure or hepatic insufficiency, the liver will not be able to metabolize this lactate, and it will be it will accumulate in the blood, and 30% is metabolized in the kidney. So there are two repercussions of this renal failure. First, it will not clear the metformin from the body also, so that leads to increased concentration of metformin, and at the same time there will be reduced metabolism of lactic acid by the kidney. So both the factor will ultimately lead to increased lactic acid. So this lactic acidosis can occur in these situations. So please remember, any condition which actually interfere with the metabolism or clearance of lactic acidosis, or the condition which can promote production of lactic acid, etc., can lead to lactic acidosis. But as I said, if it is used as per the prescribed information with all the instruction being followed judiciously, then there is hardly any instance where this metformin has caused lactic acidosis, and this is one of the safest drug available with us. Vitamin B12 deficiency is also have been reported in almost 1/3 of the subject. It may vary from 5% to 30% of the individual, and it depends more on the doses which are being used and the duration for which this metformin is being used. And it is suggested that the reason could be because of this metformin may interfere with some calcium dependent membrane mechanism which are important for absorption of vitamin B12 and intrinsic factor complex in terminal ileum. That could be the reason, probably. That is why American Diabetic Association, American Diabetic Association in its treatment guideline has recommended that you should keep monitoring vitamin B12 level frequently to check for any deficiency, etc., with metformin therapy. Another group of drugs are thiazolidinediones, and the thiazolidinediones are also called as euglycemic agent or insulin sensitizing agent, also euglycemic or insulin sensitizers also. But they always remained in limelight, these group of drugs, because there were three agents available: troglitazone, pioglitazone, and rosiglitazone. Troglitazone has been withdrawn long back because of its hepatic toxicity potential, and later the rosiglitazone was also withdrawn because of increased risk of stroke, MI, CHF, and death associated with rosiglitazone. But after the thorough further studies which have been carried out to find out whether these are actually really related to rosiglitazone use or what, the results are not very conclusive, and for that reason this rosiglitazone is still has been made available in US as a restricted access program, under restricted access program. And one can use rosiglitazone and can continue with the rosiglitazone if they are deriving any benefit out of it, if they choose to do so. That is ultimately depends upon the patient, otherwise it is available on restricted access programs. So it might make it may reappear, or it might come back to the as a established treatment for diabetes therapy maybe in near future. But this drug was withdrawn because of I said certain cardiac side effects and conditions. So this rosiglitazone controversy has in fact destroyed its the life expectancy, you can say. But we hope that the drug turns out to be a winner and joins the arsenal of antidiabetic therapy in the treatment of type 2 diabetes mellitus. These drugs, only the pioglitazone is available in India, which is available in the doses from 15 milligram to 45 milligram, and it is they actually act through binding to their action is through binding to specific receptors that are called PPAR gamma receptors. Peroxisome proliferator peroxisome proliferator activator receptor gamma. These are nuclear receptors similar to steroid receptors or thyroid receptors, and we have PPR alpha receptors also. So this bind to this PPR gamma receptors, and these receptors in tissues like adipose tissues, muscles, and liver, and they actually affect gene expression, the expression of those genes which are involved in metabolism of lipid and glucose. So they are known to cause or known to reduce insulin resistance because they may increase the sensitivity of the peripheral tissues to insulin. So they also have insulin sparing effect. So they actually act as an insulin sensitizer, means act by decreasing insulin resistance that is there. And insulin resistance is one of the major mechanism for precipitating type 2 diabetes mellitus. So when these genes are overexpressed, which are involved in glucose metabolism, so these actually leads to enhanced production of GLUT4 expression. That GLUT4 is a glucose transporter 4, which is present in these peripheral tissues and responsible for uptake of glucose from the circulation. So not only these proteins are synthesized more, they are also translocated to membrane to trap this glucose from the circulation and bring down this blood glucose level within the normal limit. So it increases both glucose uptake and utilization by peripheral tissues. But the problem with these compounds are maybe 1/3 of the population or the subjects who have been prescribed these drugs may not derive any benefit. So 1/3 of the patient may not show any effect. Only 2/3 of the individuals, the reason not known, but only 2/3 of the individuals who are actually responsive to this class of drug. And this drugs have little late onset of action because they affect their action is because of the genetic change in the expression of certain genes and all that. So that requires time. So that is why their action, full-blown action, becomes apparent only after 4 to 6 weeks. Similarly, even if they are discontinued, that the offset of action also will take time. It will take time. Similar time is also needed for their action to get over or completed or finished. They might have beta cell preservative properties also. This has been actually claimed, but to what extent this is occurring is not known. This is the mechanism of action, how these thiazolidinediones can act. You see, these are the adipocytes. The larger the adipocytes, more insulin resistant they are. Smaller the more uniform inside, and smaller they are more insulin sensitive. So what happens, because these are more large in size, insulin resistant, then that is why the insulin production from the beta cells has increased. Body requires more and more insulin to handle the blood glucose, to keep them in, keep that in under the normal levels. And these, fat cell can secrete variety of mediators like free fatty acids, TNF-alpha, leptins. These are all, responsible for increasing insulin resistance. So they all, can increase the requirement of the insulin by the body to maintain the blood sugar level in the normal level. So there is hyper secretion of the insulin. But the same, when thiazolidinediones are given, they can act on, definitely they act on adipose tissue. Most important site of action is rather supposed to be the adipose tissues. They do act on skeletal muscles and liver, but that there is always a question mark whether that is really responsible for their actions. But definitely it actually leads to production of more homogenized population of adipose tissues that are smaller in size, more insulin sensitive, with by affecting this PPR gamma receptor, they can increase the expression of GLUT4 in the adipose tissue. So that may be responsible for disposal of the extra serum glucose and all that. Not only that, because of the action on this nuclear receptor, there may be decrease in the production of all these mediators which are responsible for imparting insulin resistance in tissues. And one other thing is that that is adiponectin. Its leptin is reduced, but adiponectin is increased. So this adiponectin. So this all can lead to increased insulin sensitivity of the peripheral tissues and better uptake and disposal of the blood glucose level. This adipocyte is no longer considered as a simple cell. It is now considered as a endocrine cell, in fact, and all these mediators released by these adipose tissues are collectively known as adipocytokines. So this no longer is considered as a simple fat cell. It is considered as a hormone sensitive cells or hormone producing cells kind of thing. So this is the mechanism how thiazolidinediones can enhance insulin sensitivity and can promote peripheral glucose uptake and disposal, and can bring down blood sugar within the normal range. I have already discussed that it has slow onset and offset of activity because the actions are related to their manipulation of certain genes by interaction with PPR gamma receptors. Dyslipidemia may also be corrected partially because in diabetic patients the most common dyslipidemia is hypertriglyceridemia, and because of their cross activity or cross reactivity with PPR alpha receptor, that is also a nuclear receptor that is involved in triglyceride metabolism and its all, on which certain hypercholesterolemic drug like fabric acid derivatives gemfibrozil acts. So because of action on these receptor also, this pioglitazone especially can lead to little reduction in triglycerides as well, which is also a desirable feature. Adverse effect wise, this drug, one thing is important, that is they actually cause fluid retention, and weight gain is the result of that fluid retention. It is not an independent side effect, but it is actually secondary to the fluid retention. It can increase fracture risk in women. Fracture risk is increased in women because it decreases the synthesis of osteoblast production, or osteoblast production is compromised. The drugs should be avoided in liver disease. It has been recommended that before starting these drugs, the liver function test should be done, and thereafter periodically these liver function tests should be tested. If anybody has ALT more than 2.5 times of upper limit of normal, the drug should not be given. This is the reason why this apprehension is there, because the troglitazone was withdrawn from the market because of the hepatotoxicity only. So these drugs also have have tendency to produce liver function dysfunction, provided they are not used as per the labeling information. And because of this fluid retention, this may aggravate the sign and symptoms of congestive heart failure. That is the reason why in some countries this is not recommended for patient of heart failure. In fact, New York Heart Association 3 and 4, they are contraindicated. And pregnancy, it should be avoided because they are not safe during pregnancy. The recent controversy is also about these thiazolidinediones is that they may increase the risk of bladder cancer, and this risk increases cumulatively with increased doses, cumulative increase in the risk with when larger doses are used. But one more thing, if these drugs are being used in patients who are pre-diabetics, it can prevent the onset of full-blown type 2 diabetes mellitus. So this has protective action in those who are pre-diabetics or having metabolic syndrome, etc. Another group of drugs, because we have targeted various various areas or various mechanism by which we can reduce blood glucose level. For example, we have drugs which can facilitate loss of sugar from the urine, or drugs which can prevent absorption from the intestine, the drugs which can enhance release of insulin, the drugs which can enhance the peripheral sensitivity of the peripheral tissues, insulin sensitivity, or the drugs which can reduce insulin resistance, etc. So we have multi-targeted approach kind of thing. So in that this group of drugs that is called alpha glucosidase inhibitors are one of them, and they have targeted the intestinal glucose absorption or carbohydrate absorption. We have different agents like carbose, miglitol, voglibose. Voglibose I think is not available in US, but it is available in India and in Japan. So acarbose, miglitol, voglibose, they are all competitive inhibitors of intestinal glucosidases. These are the enzymes which are responsible for carbohydrate digestion. So they may delay absorption and digestion of the disaccharides and starches. So when these agents are used, they can inhibit absorption of and digestion of oligosaccharides, starch, and the disaccharide to monosaccharides, because ultimately the carbohydrates are absorbed in monosaccharide form. These drugs are only effective in case for postprandial hyperglycemia, and they are to be used just before each meal, so that at the time of meal they are able to act locally. They have to act locally in the intestine to prevent absorption. So they are to be taken just before each meal. They are not to be taken much before like sulfonylureas and all that, and they have no role after if you take it after 1 hour or 2 hours, they have no role. It has to be taken concomitantly with your meal. So they can reduce postprandial hyperglycemia because they have inhibitory effect on absorption. So they can reduce by 45 to 60 mg/%. That is quite significant, and thus they have insulin sparing effect because the glucose load which has been delivered to the central circulation is less. So this has insulin sparing effect. Especially this acarbose inhibits this sucrase. Acarbose and miglitol inhibit sucrase, maltase, and beta glucosidase. Sorry, this alpha glucosidase, not beta. But this miglitol can also inhibit isomaltase and beta glucosidase. This is the characteristic. And acarbose also have action on alpha amylase. This alpha glucoside is like sucrose, sucrase, maltase, and this glucoamylase. These are all actually alpha glucosidase, right? Just a minute. And this can also inhibit isomaltase and beta glucosidase, and carbose can also inhibit alpha amylase. So they have some common properties and some may be specific for particular enzymes and all that, but ultimate result is the conversion of these oligosaccharides, starches, and etc. does not, or disaccharide does not take, and monosaccharides cannot be formed. So this all needs to be given before each meal, right? And contraindication is renal disease, especially the severe renal disease. Though the acarbose is very partially absorbed, but miglitol can be absorbed from the intestine, and the flatulence and all that is a common side effect of these drugs, because of the undigested carbohydrate will ultimately be acted upon by the gut bacteria and can produce gases and all that. So it is contraindicated in IBD, intestinal bowel inflammatory bowel disease, may lead to perforation and all that. Diabetic ketoacidosis, it is contraindication in contraindicated. These are contraindicated in diabetic ketoacidosis. Only anti-diabetic drug that which is useful in ketoacidosis is insulin. And remember this thing, though this drug when used alone cannot produce hypoglycemia, but if they are used with other drugs, they may increase tendency of hypoglycemia. So hypoglycemia may increase. And when you are using treating such hypoglycemia as a result of alpha glucosidase inhibitor, patient are consuming or taking alpha glucosidase inhibitors, you cannot treat this hypoglycemia with the simple table sugar, which is actually a disaccharide table sugar, that is all actually a sugar, sucrose. You have to have pure glucose. You need to give pure glucose. So those patients who are on these therapies should keep glucose always ready or always at home, because this cannot be treated with this simple table sugar or other sweet anything, candies or etc. The side effects are flatulence and diarrhea, because this is osmotic diarrhea kind of thing. Pain abdomen can occur because of this bloating, etc. And liver toxicity is also a possibility with these agents. Got my point? So they actually they do not affect the disease process or anywhere. They just simply inhibit the carbohydrate absorption from the intestine. So this is their major task. These are relatively newer drugs, because the better understanding of the pathophysiology of the disease led to the development of or identification of the new targets for the drug and development of those agents. In the first part of this lecture, I explained you about when you give oral glucose or parenteral glucose. Oral glucose can will have a higher effect or larger effect on the release of insulin magnitude of the insulin release rather than the parenteral glucose, because these hormones that are released from the intestine are also important in releasing insulin from the beta cells. So these are called many these hormones like glucose dependent insulinotropic peptide or glucagon like peptide 1. These are the all hormones which are called incretins. So we have GLP-1 receptor agonist. We have made certain changes in this GLP-1 and we are using them as a treatment of diabetes. So we have exenatide, liraglutide, dulaglutide, semaglutide, elbiglutide and lixisenatide. But the problem with these agents are they are to be given parenterally. They are needs to be given as injectable. Only one drug which is available orally is semaglutide. That is only one agent. We all know that the patient of type 2 diabetes mellitus have defect in postprandial release of this GLP. This is actually reduced. And this actually GLP is important not only for promoting the release of insulin but also suppressing the glucagon release as a result as a response to meal. So this keeps glucagon level in the postprandial period under control. But because of the defective release of this GLP-1 in type 2 diabetes mellitus, this is not possible, and there is postprandial glucose excursion because of the enhanced glucagon release and less of insulin release. These are all synthetic analogs, have been made by certain modifications in the GLP molecule, and they all bind to GLP-1 receptor and exhibit similar effect like glucagon, like natural glucagon like peptide 1. So these drugs are also considered to have effect on beta cell mass. It is proposed that they may reduce apoptosis of these beta cells or may enhance production of the beta cells, or both the mechanism together may be active, and they can preserve islet cell mass or beta cell mass can increase. So they all can cause increased glucose dependent insulin release and other actions which are responsible for their hypoglycemic action. That is, they reduce glucagon, which I have already told you. They delay gastric emptying. So a load of carbohydrate is gradually actually delivered to small intestine, from where actually the carbohydrate is being absorbed. So the entry of glucose in the blood is slow, which is always a desirable feature, because the whatever insulin is present in the blood can efficiently control that blood glucose load, rather than a sudden gush of glucose that reaches to the blood after the absorption. So this gastric emptying is a very deciding factor, important factor for glucose absorption and all that, because it will be delayed. And there is decrease in appetite. This is considered as maybe a central effect or something, but this is also important and contribute to its their hypoglycemic action, decrease in appetite. So in glucose dependent increase in insulin release, lowering of the plasma glucagon level, increasing gastric emptying time, decreasing appetite, these are all collectively responsible for their beneficial effect in patient of type 2 diabetes mellitus. They are not recommended for type 1 diabetes mellitus. So we had first agent in this group was exenatide, which is to be given injectable. This is an injectable drug. So it has short action, because of that it was needed to be given twice daily. So that was a major limitation of the success of this therapy. So this was available in the form of solution, but now it is available as a suspension, which can be given once in a week. So but to start exenatide, one has to start with solution, then only one can switch to suspension. Semaglutide is the only drug available in this group which is available as an oral tablet, can be given once daily, or as a subcutaneous injection once per week. Semaglutide. Liraglutide is also, after exenatide, actually liraglutide came to the market, and it is having long enough half-life. It can be given once daily, and it has almost 97% amino acid homology with GLP-1 glucagon like peptide 1, and it has been recommended for the treatment of even pediatric age group, those who are 10 or more than 10 years of age suffering from type 2 diabetes mellitus. So don't consider or don't think that way, that the type 2 diabetes mellitus is the problem of older age group only. This can occur in children also, right? So this is approved for that also, other than adult. In adult, it is approved for treatment of obesity. For example, those who are having body mass index equal to more than 30 kg per meter square, and in addition to the diet and other exercise, etc. Especially, but that formulation is different. One which is used for diabetes and one which is used for obesity. Both the formulations are different. The drug is same, but formulations are different. So they cannot be used interchangeably. Recently, 2-3 days back, in fact, this liraglutide has also been approved for obesity in children who are more than 12 years of age, having body mass index, or those who are more than 60 kg in weight and having age and weight in proportion to this body mass index equal to more than 30. That is the measure of this BMI in adults actually. So this should be proportional to this. So but this children should be at least more than 60 kg in weight and should fall in this criteria, that if we calculate as per the age and this age adjusted BMI, that should be similar to around 30. So 2-3 days before just this has been actually approved, and this might make it appearance, this particular indication might make its appearance in the labeling information very soon. But this liraglutide has other problem like nausea is very common with this drug. This can cause occasional vomiting, diarrhea, etc. And and other serious side effects. That is why it is not recommended as first line drug. It is always used as adjunctive drug. serious side effects in the sense that it can cause pancreatitis, and if pancreatitis develops during the liraglutide therapy, it should be permanently stopped. It should never be given to that patient. And it has also been found that liraglutide, when used in rodents, they have shown thyroid C cell tumors. So the liraglutide is also contraindicated in patients who have personal or family history of medullary carcinoma thyroid or MEN2, multiple endocrine neoplasia 2. So these are the two serious side effects, and these are included as a black box warning. Especially this risk of carcinogenesis is a black box warning attached with liraglutide. These are the this is the natural GLP-1, which is degraded by dipeptidyl peptidase 4 enzyme, which cuts this particular glucagon here to terminates its activity. So these are liraglutide has been attached with a C16 fatty acid, like the C18 fatty acid is there in semaglutide, and albiglutide is attached to albumin, and lixisenatide, exenatide. These are all. This dulaglutide has attached IgG antibodies along with that, with a linker in between. So these are the changes made in GLP molecule or amino acid sequence, and we could make these drugs that are available today for the management of type 2 diabetes mellitus. So all are available except the semaglutide is all are available as a subcutaneous injection, but semaglutide is also available as a subcutaneous injection, but also available as oral drug. So this albiglutide, dulaglutide, lixisenatide all can be given as a once weekly subcutaneous injection, right? You can see this designer drug dulaglutide, how it has been attached to human IgG portion, FC portion of human IgG. There is a linker molecule in between, that is a spacer, and glucagon, GLP, certain sequences of GLP-1 has been taken that has sufficient affinity to bind with this GLP-1 receptors on the pancreatic beta cell to enhance release of insulin and all that. So this is these drugs can be, this particular drugs can be called as designer drugs. Other than management of type 2 diabetes mellitus to control hyperglycemia or ensure euglycemia, these drugs also have been indicated for other action, like liraglutide has already been, I told you that it has been indicated for obesity, but dulaglutide, semaglutide and liraglutide are also indicated other than type 2 diabetes mellitus, other than control of hyperglycemia in type 2 diabetes mellitus. They are also indicated for reduction of the major CV risk reduction, that is decrease in that is non-fatal MI, non-fatal stroke or cardiovascular death, or also to reduce hospitalization in adults with type 2 diabetes mellitus who have established cardiovascular disease or cardiovascular risk factors. So these are also additional indications. These are not only just to decrease the hyperglycemia and all that, until and unless this hyperglycemia is translated into some clinical benefit. That is very important. Why do we treat hypertension? Because we know treating hypertension will reduce cardiovascular morbidity and mortality. Otherwise, just bringing blood pressure level to a good looking figures which are within the normal range, but there is no effect on the cardiovascular mortality or morbidity, then there is no point in treating hypertension and all that. Ultimately, end point or the aim is to reduce those the end result of these rise in hyperglycemia and all that. Another group of drugs, because these glucagon like peptides, they are broken down by certain peptidases which are called dipeptidyl peptidase 4 especially. So these drugs can all increase the duration of not only the circulating level of these incretins, but also can prolong their higher concentration in the blood as well as prolonged action. So these drugs have been devised or designed keeping this in mind. So we have several agents available with us. This is sitagliptin, vildagliptin, saxagliptin, linagliptin and alogliptin. So they prevent degradation of incretins, and as they can increase circulating levels of both this GLP-1 and GIP. GIP is also known as gastric inhibitory polypeptide, It is same as glucose dependent insulinotropic polypeptide. Both are same. Don't consider that gastric inhibitory polypeptide is different. So both the duration of action is increased, their plasma levels are increased. So they have similar action like GLP-1 analog, like increase in glucose mediated insulin release, decrease in glucagon, right? And if these are increased, that will also have similar effect like, in delaying gastric emptying or appetite, etc. But the advantage with these drugs they are orally active. So these drugs, even if there is less GLP-1 and all that, by preventing the degradation, they can try increase the concentration of these mediators to at least towards the normal, and we do not need to give those drugs which needs to be given only through parenteral route. So but they are direct GLP-1 receptor agonists. That is the advantage, but the disadvantage is that they are all needs to be given as injection. So we can try these dipeptidyl peptidase inhibitors that are orally available and can produce similar kind of actions. These are the examples. Adverse drug reaction most commonly associated with these drugs are the nasopharyngitis is observed in lot many patients. Upper respiratory tract infections, maybe this enzyme may have some role in natural defense mechanism against infections, etc. Hypoglycemia may occur if they are in combination with other drugs. Other than that, if pancreatitis develops along with the treatment with dipeptidyl 4 inhibitor or hypersensitivity reaction, stop drug permanently. This is one has to be very vigilant, watching for these side effects, etc. This is the diagram how this GLP-1 is released from the small intestinal cells. There are special cells, I think L cells in the intestine. This GLP-1 can, if its degradation is inhibited by these inhibitors, ultimately can stimulate insulin secretion, suppress glucagon secretion, etc. Another class of drug which I said that we are trying to attack each and every possible pathway to control blood sugar level and to keep this plasma glucose well within the normal range or euglycemic range. So we have these drugs like dapagliflozin, canagliflozin, empagliflozin and ertugliflozin. They actually are inhibitor of sodium glucose transporter in the proximal tubule, S1 segment of the proximal tubule, where the 90% of the glucose is absorbed. So we can inhibit this transporter. So what will happen? Most of the glucose will be lost in the urine. So this is one of the way that we can achieve control in blood glucose level and all that. So we have this first agent which was marketed was dapagliflozin, and it has been used as an adjunct to diet and exercise in type 2 diabetes mellitus. But this is one indication. In addition to that, this has been also indicated to reduce hospitalization for heart failure in type 2 diabetes mellitus who have established cardiovascular disease or multiple cardiovascular risk factors. So in those patients, the risk of hospitalization or number of frequency of hospitalization for heart failure is reduced. So this is another indication. And these drugs are not used or do not have any utility in the treatment of type 1 diabetes mellitus or diabetic ketoacidosis. Usually this dapagliflozin is used as 5 mg OD in the morning with or without food, and the maximum dose is 10 mg. It can be increased up to 10 mg if the drug is tolerated well and if there is inadequate control of the blood sugar level. Canagliflozin is other than treatment of type 2 diabetes mellitus is also approved for patient who have macroalbuminuria, means the loss of albumin more than 300 mg in 24 hours. So it is approved in these patients to prevent development of or chances of developing end stage renal disease, or chances of doubling of serum creatinine, also decreasing cardiovascular death or this heart failure. Not only that, this is also can reduce or indicated for decreasing major adverse cardiovascular events, that is same as non-fatal MI, non-fatal stroke, and the cardiovascular death. Empagliflozin is, other than treatment of type 2 diabetes mellitus, is also approved for reduction in cardiovascular death in patients, adult patients, not children, with type 2 diabetes mellitus and cardiovascular disease. Those who have type 2 diabetes mellitus as well as cardiovascular disease, so it decreases the risk of death or chances of death due to cardiovascular reasons in adult patients. So the empagliflozin is also approved for that. Atogliflozin has no other additional indication. It is just used as an adjunct to diet and exercise in type 2 diabetes mellitus. And these drugs, many drugs, this empagliflozin, dapagliflozin, are present either available in combination with metformin, or many of these DPP-4 inhibitor like saxagliptin, sitagliptin, or lenagliptin, etc. Side effects are more common because a bulk of glucose being excreted through kidneys, so chances of urinary tract infections are higher. Anyways, diabetic patients are more prone to develop urinary tract infections, and because of increased glucose load in the urine, that leads to osmotic diuresis kind of thing. So patient may have signs and symptoms of polyuria and genital candidiasis. The load of sugar can lead to development of genital candidiasis or infection with yeast, urinary infection with yeast in both females and male. So this is are the common side effects associated with SGLT2 inhibitors. This is the diagram how this is S1 segment of the proximal tubule. There is certain areas of proximal tubule which has S1, S2, S3 segment, straight portion I think, or convoluted portion probably, where the 90% of the glucose is absorbed. Once SGLT2 inhibitors are given, this majority of the load of the glucose is actually excreted in the kidney, in the urine. So this is actually taken up by the glucose transporter on the basal lateral membrane, and this GLUT2, which actually reabsorption of this glucose from the kidney. Bromocriptine, we know bromocriptine, I will be talking about bromocriptine when I talk about this pituitary hormones and related drugs, etc. This bromocriptine is a dopamine receptor agonist. It had role in Parkinsonism, but no longer used in Parkinsonism. It is used in galactory, this prolactinoma, etc. Bromocriptine has role in prolactinoma and all that. Also, I think in acromegaly. It's in quick release formulation, that is immediate release formulation. That is actually, it has short duration of action. Maybe it has extended release formulation as well. So this quick release formulation has been approved for diabetes mellitus, not as a monotherapy, as an adjunct to diet and exercise in in type 2 diabetes mellitus. And this drug does not affect either insulin sensitivity or insulin secretion. It has no effect on secretion, so it does not act as an insulin secretagogue. It does not act as an insulin sensitizer. Then how does it act? This is believed that its action is related to most probably action in the CNS. And because being a dopamine agonist, it probably affect dopaminergic neurons or dopaminergic pathway of the hypothalamus that are involved in maintenance of circadian rhythm. And probably this bromocriptine actually leads to this dopaminergic mediated resetting of circadian rhythm hormone release. And these hormones which are important are growth hormone, prolactin, and ACTH. These hormones are known to increase insulin resistance. They are diabetogenic, so and so. So there is resetting of release of these hormones, etc. might be responsible for its effect in blood sugar control. It might improve insulin sensitivity of the tissues. This is reason for it is increasing insulin sensitivity, in fact. So this is probably the reason behind its use or its approval by US FDA for the treatment of, but you will hardly see any patient receiving bromocriptine. I have not seen any patient receiving bromocriptine till today. Maybe effectiveness is modest. This is not very good, and it should be given in the morning with food, and this bromocriptine, this all dopamine agonist, levodopa, bromocriptine, etc., they can cause nausea because there are dopamine receptors are present on CTZ and vomiting center, etc. So nausea, occasional vomiting can occur. Orthostatic hypotension, because dopamine, if stimulated by higher concentration, dopamine receptors are present, they can lead to vasodilation, all that. So orthostatic hypotension is very common. Headache can occur, etc. So these kind of problems are quite frequent with the treatment of bromocriptine. So this might not be, maybe the tolerability may be an issue in treatment of diabetes mellitus, as the treatment needs to be taken on long-term basis. Cholecyvalum is anionic. We talked about hypocholesteremic drug or drug which are useful in reducing blood lipid level, hypolipidemic drug. This cholecyvalum was resins, actually, anion binding resin. So this cholecyvalum has also been approved for type 2 diabetes mellitus as an adjunct therapy, but the mechanism how it works is not known. But I will show you one diagram how it can work, because there are assumptions that cholecyvalum may act through these pathways, may interact with these pathways. Actually, this cholecyvalum, these resins were actually used in hyperlipidemia just to decrease, blood lipid levels. And their major mechanism of action is that they bind to highly positively charged this bile acids in the intestine, and prevent their enterohepatic recirculation, because these bile acids are 95% are recycled, they are reabsorbed in the terminal ileum. So because binding to these resins, etc., these drugs are not, this bile acid is not able to be absorbed. So what happens, this bile acid needs to be synthesized by the liver, and in that, the liver uses cholesterol, and this cholesterol is being catabolized in the formation of bile acid. So this can reduce serum cholesterol level and all that. So that was the reason behind that. But these bile acids, we should know that these bile acids are actual natural ligand of the FXR receptors, which are nuclear receptors similar to PPR alpha gamma. These are farnesyl X receptors. So when there is reduced bile acid, there is reduced FXR activation, and this FXR activation has multiple effects on the glucose and lipid metabolism. So maybe the reason behind maintenance of blood glucose level or correction of blood glucose level by the cholecyvalum is probably related to this FXR activation level, etc. capacity. In addition to that, cholecyvalum may also impair glucose absorption from the intestine. This could be an additional action. Look at this diagram. Once we take the food, there is release of bile acids. This bile acids is undergo enterohepatic recycling, and this is further reabsorbed and released from liver. 95% is reabsorbed. But the drug that does not allow this bile acid to get absorbed, this cholestyramine, because it binds to these bile acids and leads to their excretion. 95% or more are excreted. So this actually leads to what this because of the decreased bile acids, this activation of FXR receptor is reduced, because they are natural ligand of this FXR receptor. So reduced activation of FXR receptors actually is associated with the decreased glucose absorption. This is the one action. And in the liver also, this FXR activation, because it is reduced, otherwise it actually inhibits this glycolysis, and this inhibits this lipogenesis. So what happens, once this FXR activation is reduced, this glycolysis will enhance. So this will lead to more and more glucose being shunted to glycolytic process, and more glucose will be utilized to produce similar amount of energy as compared to TCA cycle. And lipogenesis is increased, so that increases the triglyceride levels also. VLDL triglyceride levels. In addition to that, the bile acids can also activate certain membrane receptors, though it acts through nuclear receptors, but membrane receptors are there that are called mBAR, membranous bile acid activated receptors, bile acid receptors, mBAR. These are G protein coupled receptors, also known as TGR5. So these are activated, and these activation leads to increased release of GLP-1 from the L cells in the intestine. L cells. So there is increase in GLP-1, and this GLP-1 very well can increase insulin release as well as decrease glucose level. Not only that, this will also decrease glucagon, will cause also glucagon suppression. So these effects all are actually suppressed by FXR, but when FXR activation is suppressed, so these things becomes wherever you see this red arrow mark, upside red arrow mark, these actions are all increased because of the decreased activation of FXR receptors by bile acids. Cholesterol and these cholestyramine, etc., these drugs are not meant for a systemic absorption. They are not absorbed or modified. So side effect is usually constipation. They are to be taken with enough fluid, otherwise they can cause even GI obstruction or indigestion. It can cause flatulence, it can cause, and it can impair absorption of multiple drugs. Especially one should avoid, it can reduce fat soluble vitamin, can produce fat soluble vitamin deficiency, can reduce their absorption. It can reduce levothyroxine, L-thyroxine. I am talking about only endocrine drug, mainly important. OCP failure, because OCP absorption can be affected. All these things can be impaired by this cholesterol, and should be avoided in hypertriglyceridemia. As you saw that because of this effect, they can increase triglyceride level because lipogenesis is increased, so more and more triglyceride is formed. So this hypertriglyceridemia this is the side effect of these drugs. And any patient who have prior history of triglyceridemia, because pancreatitis, because of hypertriglyceridemia, this drug should not be used at all, and avoid in other conditions like esophageal, gastric or intestinal disorders because of these side effects, especially the indigestion, flatulence and constipation. Aminomimetics, that is one agent we have available with us, that is pramlintide, and this pramlintide is as an analog of amylin. And we discussed about amylin in the last class, that amylin is a synergistic hormone to this is a synergistic counterpart of the insulin, because it is released with insulin in response to meal, though the ratio is 1:100, but this can act in the CNS as well as in the periphery. It can delay gastric empty, it can affect appetite by acting in the CNS, and it is important in control of regulation of short-term food intake, and insulin is responsible for regulation of long-term food intake. So this amylin actually is have tendency to self-aggregate, and it is insoluble. That is why it is difficult to be utilized in therapeutics. So people have made certain changes in its amino acid sequence, and that is more soluble and have no tendency to get self-aggregate, and it is equally potent. So this pramlintide is the result of that alteration in the amino acid sequence. But this is available as an injectable hormone because it is a peptide, and it is if injected can have anti-hyperglycemic agent. This reduces post-meal glucose excursion, lowers glucagon level, slows gastric emptying, decrease appetite, and it has actually effect on hepatic glucose output also. So that could be the reason that post-meal glucose excursion is inhibited. That could be result of the glucagon also, reduction in glucagon, but it has direct effect on the glucose hepatic output also. It reduces glucose hepatic output. Problem with pramlintide that it cannot be mixed with any type of insulin. It is to be given separately. And this is the only drug which can be used in both type 1 and type 2 diabetes mellitus other than insulin. Otherwise, no drug is used in both the conditions. Side effects, yes, hypoglycemia, but hypoglycemia as such is never caused by pramlintide, has no such property to cause hypoglycemia, but it is always used with always used with insulin. It should not be used alone. It can increase the tendency of hypoglycemia caused by insulin or other drugs, but it does not have property of causing hypoglycemia. But this nausea is very common with this drug. Vomiting can also occur, right, despite injectable. This is a pramlintide amino acid sequence. You see at the position 25th and 28th and 29th, 3 proline amino acid has been substituted for alanine and 2 serine at these positions. So that has led to this amylin. After these substitution, it actually became more soluble and is less likely to self aggregate, and without loss of its potency and all that. Pramlintide is to be used with insulin, and these are the doses of the pramlintide, which is equal to, it is 1/6 less potent than the means it is actually, if you see, the 15 microgram is equivalent to 2.5 unit of insulin. You should understand this. So these are the strengths, and these are the 6. You can divide any microgram of pramlintide, means the insulin is 6 times I can say, but it is not a direct relationship because this is in microgram, this is in unit. But you can, so if you are talking about 15 microgram of pramlintide, you should 1/6 of this number would be the unit of insulin, which is equal in action to this pramlintide. So whenever we start this pramlintide, first thing we do is to reduce mealtime insulin. Mealtime insulin, if somebody is using rapid insulin like insulin lispro, insulin spart, glulicin, or somebody is using soluble insulin like that is short acting insulin, clear insulin, regular insulin, etc., or somebody is using pre-mixed insulin which has combination of NPH plus soluble insulin, that is short acting insulin, usually in 70:30 ratio. That is called mixed start, available as mixed start. So any mealtime insulin which we are using, that is to be reduced by 50% first, and then you add pramlintide. Otherwise there is high likely chances that severe hypoglycemia will occur. So you reduce insulin doses, start titrating the doses of pramlintide. You increase 15 microgram, 30 microgram, 40 microgram depending upon the tolerability. Ultimately the 60 microgram is the recommended maintenance dose in type 1 diabetes mellitus, and 120 microgram in this and along with that, now you adjust insulin doses to optimize glucose control. First you reduce 50%, add this pramlintide, and accordingly you can once you reach to maintenance dose of that, and then adjust insulin dosage, that how much extra insulin needs to be added to achieve sugar control. So this was all about anti-diabetic drugs, the drugs which are useful in treatment of diabetes. But we are talking about pancreatic hormones. So glucagon is one important hormone which has therapeutic utility in certain situations. So that is why this needs to be discussed as well. It is also a single chain amino acid, 29 amino acid peptide, smaller in size than the insulin, and other than in contrast to insulin, it has only single chain. And it is extensively degraded, and that is why it has short half-life, similar to insulin, like 3 to 5 minutes, same as insulin, but it is degraded by both liver, kidney, in the blood, as well as the receptor mediated metabolism also occurs for this glucagon. That is why it is very short acting. Glucagon receptors are G protein coupled receptor, you can see, and they are linked to adenyl cyclase, that is GS, suppose stimulatory. So this adenyl cyclase are activated, and this leads to production of ATP to cyclic AMP. Cyclic AMP level is increased, and the cyclic AMP converts protein kinase A to activated protein kinase, and this protein kinase can phosphorylate glycogen synthesis A, so it becomes inactive. So it promotes glycogenolysis. It means it inhibits glycogenesis, and promote glucogenolysis means it will release glucose from glycogen. So either inhibition of glycogenesis or glycogenolysis, both are actually is promoted by this glucagon. So this can lead to hyperglycemia, but this hyperglycemic effect is many a time useful, and this again can be activated by phosphatases. As we know, this can be activated by glucose 6 phosphatase or insulin, this protein phosphatases. Whenever there is a kinases act, the action is reversed by phosphatases usually, So this is the action of the glucagon, and important is this increase in cyclic AMP level in the tissues or specific cells. This can binds to GPCR on liver cell. We have discussed that. So the actions are glycogenolysis, gluconeogenesis, and ketogenesis. So glucagon is a ketogenic hormone. This can lead to precipitation of ketogenesis. It raises blood glucose from stored hepatic glycogen. Why? Because as told you, this is involved in glycogenolysis and all that. So whatever hepatic glycogen is there, it can cause this, and this action may be useful in certain situations, like patient has hypoglycemia as a result of overdose of some drugs, or hypoglycemic drug, etc. We can use this glucagon to raise blood glucose by stimulating glycogenolysis, etc. But for that there should be enough hepatic glycogen reserve. But it does not affect skeletal muscle glycogen, because skeletal muscle do not have glucagon receptors. No glucagon receptor. They are present in the liver only. And in pharmacological doses are always higher than what is actually physiologically revealed. So if you are using it for pharmacological purpose, that might increase insulin release. It can increase insulin release from beta cells, but insulin inhibits glucagon release. It is you can see this. And this catecholamines release from the pheochromocytoma and can release calcitonin from medullary carcinoma of thyroid. The pharmacological doses, so one should be aware of these effects of glucagon being administered exogenously. The cardiac effects, the glucagon has very potent inotropic and conotropic effects, just like adrenaline and all that. So this can cause increased contractility as well as increased heart rate, similar to stimulation by a beta receptor agonist. Similar, I told you, noradrenaline or adrenaline, similar to them, it can produce cardiac stimulant effect, and this will have bearing on treatment of certain toxicity. Smooth muscles, it can cause in higher doses, if used larger doses, it can cause profound relaxation of intestine. And this effect is supposed not to be due to activation of adrenal cyclase that leads to increase in cyclic AMP. Not due to that. It has been proposed not because of this. But this cardiac stimulant effect is definitely due to increase in cyclic AMP. The same is done by the beta receptor agonist also. So this cyclic AMP, but this cyclic AMP increased, but without the need of beta receptors. It is not through beta receptor, it acts through glucagon receptors present on the heart. So these beta receptors are not required to produce cyclic AMP. Clinical uses, as I said, because of its action on hepatic glycogenolysis, it can be used in severe hypoglycemia, especially if patient is unconscious and oral feeding cannot be done, or the parenteral glucose is not available to be administered. In that case, the recombinant glucagon which is available as 1 milligram vial, that can be given either IV, IM or subcutaneously. In fact, many diabetic patients who are on insulin therapy should carry this vial along with them. This can be life-saving in certain situations where patient meets with severe hypoglycemia because of insulin tight control of sugar level with insulin therapy. It is also used for endocrine diagnosis because, as I said, the pharmacological doses of glucagon causes insulin release. So we can measure beta cell secretory reserve in patient of type 1 diabetes mellitus, but we need a stimulus to release it, insulin, so that we can measure C-peptide, which is released in equimolar concentration similar to insulin. So this this 1 milligram glucagon is used as IV bolus to promote insulin release, and with insulin the C-peptide will also be released in equimolar concentration. So because of the long half of the C-peptide, we can measure C-peptide, and it is its estimation is not affected by the insulin which is being given for the treatment of diabetes mellitus. This is the advantage. So glucagon can be used to stimulate insulin release in such situations. Another useful activity of these glucagon is the treatment of beta blocker overdose. This is the drug of choice. In fact, many times it has been asked in PG entrance examination, because of the beta blocker toxicity or overdose, all the beta receptors are blocked, and so even if you give adrenaline, all that will not, if it is a severe toxicity, then there will be no effective reversal of the effect, cardiac depressant effect of the beta blockers. But if you use glucagon that act through the different receptors, not at all bothered whether beta receptors are vacant or not, they can increase cyclic AMP level without interacting with the beta receptor, and can restore the cardiac activity. So this is how this is recommended as specific antidote in case of beta blocker toxicity. Use in radiology is very commonly used in radiological investigation for visualization of the bowel, because it has very good profound smooth muscle dilatation property, and can dilate bowels. For that reason it is used extensively in radiological investigation, but it is also not devoid of side effect. These kind of drug can also, all drugs are in fact associated with some or other kind of adverse effects. This can also lead to transient nausea and occasional vomiting, and shouldn't be used in patient of pheochromocytoma, as I have already told you that the pharmacological doses of this can lead to enhanced catecholamine release. So in pheochromocytoma, that might lead to sudden rise in blood pressure and can result in a stroke or etc. This hypertensive crisis kind of thing. The end stage of uncontrolled diabetes mellitus is diabetic ketoacidosis. It is more commonly encountered in patients who are type 1 diabetic patient, because there is severe or absolute deficiency of insulin, and in type 2 diabetic mellitus patient it is not that common, because there is sufficient insulin that can prevent ketogenesis but cannot control blood glucose level. And they are actually, type 2 diabetic patient develops more commonly hyperosmolar diabetic coma. But this diabetic ketoacidosis is maybe sometimes the first presentation of the patient to the physician, and first sign of the diagnosis that the patient has type 1 diabetes mellitus. So these are the symptoms of diabetic ketoacidosis: nausea, vomiting, fatigue, weight loss, hunger, increased urination. So because of this nausea, vomiting, increased volume, urination, etc., because of uncontrolled diabetes, because there is no insulin, etc., patient is dehydrated. Drowsiness, thirst, abdominal pain is very characteristic, may be mistaken for something else. This is something. Thirst is also the sign of, because the patient is losing fluid and all that, and the drowsiness, etc., may be the sign of impaired consciousness and all that. So these are the constellation of signs and symptoms that are encountered during diabetes ketoacidosis. So the patient have severe fluid deficit, so we need to replace the fluid. First of all, 4 to 5 liter of fluid is required in such patient. They are so deficient in fluid requirements, and that is to be administered within 8 hours. So initially we have to push this fluid at a higher rate, that is 1 liter per hour. Normal saline we usually use For first 1 to 2 hour we give at a rate of 1 liter per hour. Afterward we decrease the rate to 300 to 400 ml per hour. 300 to 400 ml per hour. But if if you find that this sodium serum sodium is less than this thing 150 milligram equivalent, then you can shift to you change to half normal saline, because if there is an increase in if more than 150, if this is more than 150 is sodium 150 milli equivalent, then you shift to normal saline, half normal saline, rather than giving the normal saline. And once the blood sugar level falls to 250 milligram percent, the one should change to other fluid like 5% glucose, because it will reduce the chances of sudden hypoglycemia, as well as sudden decrease in blood glucose level may precipitate cerebral edema. That is also that is why it is needed to be one should change to another fluid like 5% glucose. And along with fluid replacement therapy, we should administer insulin that can be administered IV. And here the short acting insulin, that is regular insulin, is important, because that is present in hypoglycemic form, but when it is given as IV, though when it is given subcutaneously, it takes time to act. But here, once given IV, it is immediately diluted by the blood and immediately forms monomer. You can also use rapid acting insulin like insulin aspart, etc. can also be used in diabetic ketoacidosis. So usually we use 0.1 unit per kg body weight of the patient as a IV bolus, just to prime the tissue receptors, insulin receptors, and continue infusion similarly 0.1 unit per kg per hour as an infusion. And we wait for 1 hour. If in 1 hour there is no fall in serum glucose by more than 10%, then we can repeat this bolus dose once again. We can repeat this dose, right? And once the levels are around 250 milligram percent, we can also use subcutaneous insulin. No need to give infusion, etc. We can start, though one can continue with infusion, but we can start on subcutaneous insulin as well. Potassium loss is also high in such patient, that is because of the vomiting, etc., and in urinary loss of potassium. So it could be to the tune of maybe 200 milli equivalent of total deficit, maybe 200 milli equivalent potassium loss in the body. But patient may or may not present with hypokalemia, because if patient is in acidosis, what happens in acidosis, this potassium is actually driven out of the cell. So you will not find hypokalemia. So don't be very happy that the patient has normal this potassium level, etc. First of all, if you find hypoglycemia, replace it. If it is less than 5.5 milliequivalent per liter, we know it is almost the normal range. But if it is less than 3.5 milliequivalent per liter, replace it with higher speed, And higher speed replacement with higher speed is required when you treat patient or give bicarbonate therapy. Because patient is in diabetic acidosis, ketoacidosis, keto acids are formed. So that is metabolic acidosis. There is a condition called metabolic acidosis. So in acidosis, we need to, correct acidosis, we need to give alkali from the outside. So what happens the moment you correct acidosis, this potassium will go inside the cell. Because of the acidosis, it was outside. But as you start by this therapy, this all will go inside the cell. So that will suddenly present as hypokalemia. So that is, don't be happy that if you find that these potassium levels are normal. So we can use 1 to 2 ampoule of sodium bicarbonate, which has almost 44 milli equivalent of per 50 ml of this bicarbonate ampoule. One ampoule has 50 ml volume, which delivers 44 milli equivalent of bicarbonate, added to 1 liter of half normal saline. Why half normal saline? Because otherwise it forms this combination forms hypertonic solution. And in addition to that, you add 20 milli equivalent of potassium chloride and infuse over 1 to 2 hours, right? Or you can do, if you do not have half normal saline, you can add this in 400 ml of sterile water. You can add 1 to 2 ampoule of sodium bicarbonate plus 20 milliequivalent potassium chloride. That can also infused if you don't have half normal saline. But the solution here only you have to use only 400 ml of sterile water. And once the patient starts feeding or eating, then you can administer NPH and long-acting insulin. You can start giving. Otherwise, patient was kept on only regular insulin up to then. But once patient start eating and all that, you can see how this occurs. This insufficient or absent insulin. This leads to increased glucagon. Increased ketogenesis, converted to ketones and all that. And because of the decreased insulin, there is lipolysis, so glycerol is released, fatty acids give rise to converted into this ketone bodies. This is glycogenolysis, gluconeogenesis, ketogenesis, all is facilitated. Other than there is because of the less of insulin, so there is catabolism of the muscle tissues, amino acids are released, and these amino acids are converted in the liver to through gluconeogenesis into glucose, and this glycogen change, glycogenolysis is occurring, all can increasing glucose level as well as the ketone bodies. So there is elevated glucose, there is ketosis, there is acidosis because of these ketone bodies. These are acidic in nature, they can acidosis. So this triad is called diabetic ketoacidosis. So this is all about the treatment of diabetic ketoacidosis, which is the most life-threatening situation one patient of diabetes may come across, especially type 1 diabetic mellitus patient. This is acute life-threatening condition. Although there are several complications of diabetes, right from neuropathy to retinopathy to nephropathy, all that, but this is the most dangerous acute complication when a patient of type 1 diabetes can have. So guys, this is all about the anti-diabetic drugs. Hope if you have understood everything. If you have any doubt, you can if you are on have Unacademy learning app, you can directly send me message if you follow me, and I would definitely reply to your query. But once again, I would need to tell you that have this Telegram app and be member of this group, so that you can receive all the notification regarding the classes and all, that timetable for classes, and we many times shares the link of also our lectures and all that, so that you can directly click there and start watching YouTube. You don't have to search for a particular lecture on the YouTube, etc. if you are watching it later, right? There are several advantages with this subscription based service of Unacademy, that is known as Plus. So I have already elaborated its important features, that the live classes are more interactive and you have more opportunity to interact with the educator, ask questions, ask queries, etc. And it keeps you going and keeps you informed about your standard, your capabilities and your performance in comparison to the group, and makes you more competitive, etc. And we allow you to know your deficiencies, your weaknesses, etc. Also, this gives us also an opportunity to find out where exactly the group is lagging, which area needs to be actually addressed particularly. And there are variety of test material or course material is available in the form of test series, quizzes with their analysis and all that. And the live doubt clearing session is a cherry on the cake kind of situation. So you must actually be on this platform to derive the maximum benefit out of if you want to crack examination more likely means, or if you want to crack the examination with higher probability, then you should definitely be on this Plus platform. You all have this learning app, but ask your other friends also to download it, and they can also watch the lectures on this Unacademy learning app that are presented as special classes. So I am taking antibiotics on a special class, antimicrobial agents, and if you do not know, then please please understand this special classes gives you an opportunity to interact with educator. This is the best thing. And also, if you follow the educator on this Unacademy learning app, that you can send messages. So if you do not have this app, download it, install it, and attend these special classes. I am teaching there antimicrobial agents, so take advantage at both the places. So viral, make this information viral so that other guys can also join and take benefit of these free classes. And this platform is will give you a feel about how the NEET PG plus NEET PG plus would look like actually. This is just a kind of trailer of NEET PG plus. So if you have decided to, suppose you want to join, you have to go to this using this app. You have to go to the manage goals, where you have to select NEET PG, and under NEET PG you have to select this plus, and you can get subscription. And there are though these subscription is available from 1 month to 24 months, but we recommend these 2 periods or durations which are actually important. This is for those who are in final year and etc., and this 12 months is actually needed for almost everybody. You can't derive full benefit or can get full benefit by remaining attached to the Unacademy for a month or so. That is not going to make any difference. It will not improve or will not bring any drastic change in your performance or like this. But don't forget to apply this referral code that will make eligible for 10% discount immediately. So you need to pay less, and you can pay by any digital method which you have and you feel convenient with. So guys, anyways, you are enjoying this NEET PG live daily. You are enjoying every day different lectures, etc. That too all free of cost. So be here and be there on the special classes also. And if you join plus, that is the one-stop solution for all your need. You don't have to go here and there. That will take care of each and every requirement of yours and will definitely help you crack the PG entrance examination which you are looking for. So guys, with this I think I should complete this topic. But once again I am reiterating, please use my code, because this code will avail you 10% instant discount on the subscription charges. So don't forget, apply this code Dr. Pramod. And with that I finish this topic, and thanks for watching, and it's time to say goodbye and good night.